This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details. This episode is sponsored by the International Critical Care Paramedic Group. So the ICCPG unites regions worldwide to enhance paramedicine through global knowledge sharing and improved communication amongst critical care paramedics. So following the success of their inaugural 2022 conference, which gathered over 600 paramedics from across the globe, the ICCPG is thrilled to announce their second conference on January 30th, 2025. So the first event, hosted by the UK College of Paramedics, featured speakers from the UK, Australia, New Zealand, Canada and South America, discussing the vital role and unique challenges of paramedics in their regions. So the 2025 conference aims to bring together paramedic professionals worldwide, exploring topics including case studies, followed by in-depth discussions on clinical training, leadership or research aspects. So don't miss this chance to connect with peers, learn from international experts and advance global paramedicine. So mark it in your calendars for the 30th of January 2025 and stay tuned for more details about this online event. For more information, please head over to the show notes. This podcast is sponsored by the University of Hertfordshire. The University of Hertfordshire offers comprehensive undergraduate and postgraduate programs in paramedic science, preparing students for a successful career in the field. So their BSc Honours Paramedic Science programme features specialist teaching spaces and indeed advanced simulation facilities for hands-on learning. A dedicated paramedic teaching team comprising experienced professionals bring real-world insights into the classroom and help students gain practical experience. Students gain practical experience through placements in the London Ambulance Service and the East of England Ambulance Service as well. The university is strategically located, offering excellent access to London, the M25 and indeed the M1, enhancing placement opportunities and networking. The university also offers the MSc Paramedic Science, so pre-registration course, and this emphasises innovative teaching methods utilising online resources, virtual reality and state-of-the-art simulation kits. So research active teaching staff with a national and international profile provides students with the latest knowledge and practice guidelines. With over 25 years of heritage, the programme has a strong reputation and a successful track record. Graduates enjoy excellent career prospects supported by the university's robust network and industry connections. The University of Hertfordshire's Paramedic Science programme combines theoretical knowledge, practical experience and indeed research opportunities supported by cutting-edge technology and a strong professional network, making them an excellent choice for aspiring paramedics. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast. On this International Paramedic Day, the Monday, the 8th of July. So what to do in the episode is really celebrate International Paramedic Day by having a conversation with some of my fellow co-hosts on the Pre-Hospital Care podcast. So today what we're going to do is really explore some of the diverse roles within the paramedic field. We're also going to share their experiences and also discuss some of the challenges they face. Also look at some of the advancements which have transformed our profession. So whether it's responding to emergency calls or indeed collaborating with other healthcare providers or engaging with the community, paramedics play a fundamental and indeed essential part in the healthcare system. And this is what we're going to unpack in today's conversation. So welcome, Lisa and Carl, to the podcast.
Hey, Owen.
Hey, everyone. How are we doing? Nice to see you again.
Really good to see you both, actually. I just wondered, just for listeners, they've both heard your voices on the podcast on separate sessions, but I just wondered, just for listeners, if you could just introduce yourselves. Maybe Lisa, if you could just go first and unpack the spectrum of roles that you undertake.
Yeah, sure. So I have many hats, as they say, I guess. One of them's an EHAT, so that's not an. Just clarify, that's not an electronic hat that I sort of wear. It's I actually work for EHAT, which is Essex and Herts Air Ambulance, as their education lead, which means I have the privilege to be involved with a lot of clinical and professional development for our team, for our doctors and our paramedics, and to lead on some of those opportunities that we're developing for people. And so that's a real privilege role that I have. I also work as part of the critical care team who lead the Advanced Clinical Practice Masters at St George's University of London. I've been invested in that for really quite a long time now, involved in postgraduate education, and I really love it's a real special place that brings together some pockets of the critical care network from across the country, really. A lot of different air ambulance teams. The paramedics come to study together there, and a lot of the local advanced practitioner teams, they also come to study there. So we have this lovely environment where people discuss practice and development and work to break down barriers and develop each other's systems, actually. So there's a really lovely thing to be part of. And then I work clinically as an advanced paramedic practitioner for London Ambulance Service. And I've been part of that team for a long time and watched that system grow and develop into really an amazing, mature system for critical care paramedics in a very busy urban setting. So that's me.
And Carl, to yourself.
Yeah, my name's Carl Betts, and I'm a quality improvement lead at Yorkshire Ambulance Service, and also a paramedic by background, working at Yorkshire Ambulance Service. Yeah, the quality improvement world at the minute is a really big growing part of the pre-hospital world, and I'm really proud to be a part of it at this really important time.
So, I mean, that's fantastic. We've just really got you, Stephen, there amongst two of our staff. We two hosts, we've got a real disparate array of roles and indeed and responsibilities within what is an ever-expanding field of paramedicine. And I guess my first question really is around just how the role and how the profession has seen this explosion and indeed proliferation of paramedics into diverse roles over the last 10 years. I suppose initially, and to you, Carl, initially, what from your side, how have you seen the diversification of the profession in the past number of years?
We've now got options. Years ago, especially as paramedicine, you had one place to work, and the one place to work was the local ambulance service trust, and that was it. And you had no other options. Whereas now what we've got is we've got options to work in every part of basically every system within the NHS, with every system within healthcare, especially in the UK. You know, you can be a part of it. And especially now that there's advanced roles, that there's a lot of change within the actual role of paramedicine. There's now just doors that open left, right, and centre, linked to the education pathways that Lisa's talking about, which we never ever had. So now, if you want to work in prisons, if you want to work on a cruise ship, if you want to work, and you're respected as a role, because for years, the paramedic world, we weren't, as a profession, we weren't overly respected. We were just people who worked on ambulances. Whereas now, the profession has worked so hard to get itself accepted. And if we hadn't got accepted, we wouldn't be doing what we're doing. We wouldn't be doing these other roles because it would just never be allowed. And that's one of the things that the ambulance service, especially in the UK, I think is struggling with now, because that pot of talent, that pot of people, they're not solely sticking to the ambulance service anymore. So therefore, you've got all these options. And actually, I don't want to work shifts all the time anymore. So why do I want to do that? And I enjoy primary care. So I'm just going to go and, apply to work in primary care as that role, because that's where I get the interest. But then you're losing an awful lot of really, really good clinicians out of a sector that really does need them as well. So it's how we can balance that up between the loss and gain, and how we can keep the workforce on a steady ship.
And to you, Lisa.
I mean, yeah, so my world is mostly seen it even in my lifetime in critical care, how much things have changed. When I first applied into the HEMS world, essentially you had to be seen as a good paramedic. I don't know really what that meant, but I think it was assessed as somebody who knew their health inside out, somebody who probably knew their IHCD manual in those days, for those who remember that, and somebody who could basically keep calm under pressure and bring a team together. That was all that was required of us a decade or so ago. And now, when we're looking to recruit people into those roles, now the profession has evolved so much more. The university, I think, has been a fundamental part of that. We expect people to be able to talk around their practice, to talk about the evidence base for their practice, to understand the nuances of practice. And that's at entry level, really. And it's the load that people are expected to take on to learn, scope of practice that they're transitioning into. It's huge actually now. And I'm always really humbled by the people applying into these roles because they bring such wealth of knowledge that frankly I didn't have when I came to this role. And it always, every time we recruit, it reminds me how far we've come and what we're expecting of people now is so much more than what was expected of people 10 years ago. Genuinely, I wonder whether I would have got the job if I'd applied for it with what's required of people now. But it does make the point of how much things have moved on, and I think probably I am biased, but I think probably a big part of that has been the move in the progression towards higher education, which at the beginning was extremely controversial and understandably so because it was a big challenge for the workforce. Some extremely experienced, excellent paramedics were being confronted by some barriers, really, to be able to engage in developing themselves and in developing the profession. And those barriers were very real. Some of them were met by the employers for time, study time, financing that. Some of the very real barriers were about their own educational development and putting themselves in the classroom, being exposed in a very different way to how they would feel, they could manage the most difficult, complex scenes under pressure. But the pressure of walking into a classroom and being tested academically was a whole different mental barrier for people that had to be overcome. And I think we are now at the point where most people, I hope, have been supported to develop. And that development is really, really showing through now in all of the opportunities that are available to people and all of these ways that the profession is pushing forward in so many different ways. Carl's alluded to some, and certainly I get to see how people now have the opportunity to specialize and advance levels. And actually, I think that the paramedic world isn't just we're not just influencing paramedicine, we're actually starting to push forward other medical disciplines as well by showing what can be done. And probably the motivation for that has come from the need of our patients, because a lot of medical disciplines have noticed now that the most important phase for somebody might be the point at which their medical event is happening, and engaging in those early minutes, that early phase of time is so crucial. We've seen other medical disciplines come in streams more and more to try to support that. Also, we've always felt, I think, that our patients are their needs have always outweighed what we've been able to offer them. So there's been an internal push from paramedics to want to do more because we see the opportunities there. And there's been so much need amongst our patients to be able to do more for them. So there's been that drive. And it's great, really, to see where we've come to with all of that.
And something powerful, actually, that you both mentioned is that there has been large segues or pathways opened up for paramedics. One of the big elephants in the room has been primary care, partly because it's proliferated within pre-hospital care. A large part of pre-hospital care is primary care. And, innovative ways to stream patients into primary care pathways. But something that Carl notion towards is, the pull, certainly the early years pull, where paramedics aren't doing as much time on the road on ambulances, pulled into GP surgeries. But this, and to your point, Lisa, about being backed by education, so there is the post-registration, postgraduate certificates and courses and prescribing courses to support the movement of paramedics, certainly into lots of disparate roles, as Carl mentioned, and indeed yourself. But I think the chasm, which it's been most obvious, has been that shift into primary care, whereby there's been a real need for 24/7 care, because primary care has never been 8 till 5 or 8 till 6. It really does need to be, and it goes to show the versatility and flexibility of paramedics to fill that gap, with a robust package of education and governance behind that. So that kind of leads me into another segue, or indeed something which has evolved over the last few years. And I'll come first to you, Lisa, because it really has affected your world, in critical care, around the evolution of triage and dispatch. Indeed, the evolution of emergency operations control rooms, so EOCs or OCCs, these operation control rooms, and how we deal with calls at source. Could I get you to maybe speak to how you've seen the face of pre-hospital triage and dispatch change in the last few years?
I think this goes back to actually what is a paramedic, and we've suffered a bit of an identity crisis maybe over the decades that we've been in existence. Good way, because it's made us sort of question, challenge, and reinvent ourselves again and again. And maybe we're getting to a point actually where some of the terminology that's traditionally been used isn't that helpful anymore. Like pre-hospital, some of our colleagues would rally against that and say actually the focus of their role isn't before the hospital phase. It's entirely within there, and that patient's never going to go to hospital, quite rightly so. So pre-hospital is probably not. Maybe it may be a word that we challenge as we move on, and also paramedic. I mean, para being alongside, parallel to medicine. I don't think that's quite where we are anymore, and I wonder how long we'll stick to that title and want to define ourselves as paramedics. And interesting that you've brought triage into this, because I see us as an evolving speciality within medicine, and actually triage and dispatch and remote patient conferencing is a whole medical discipline in itself, and it's certainly becoming that way in urgent care for sure. In critical care, there's so much opportunity now that technology allows for us to be able to see patients instantaneously, for us to be able to actually treat the patient through being the clinician on scene with them, through what we can see and what we can coach those on scene to do, from opening an airway to delivering effective CPR or improving hemorrhage control, even obstetric emergencies. There's so much opportunity now to use video conferencing. Perhaps we're not quite there with the whole system readiness to trust in that. The technology is certainly there for this to be a medical speciality that we don't just hear and dispatch or interrogate the call and dispatch a team. Seeing the patient and treating it, see and treat now rather than just hear and dispatch. So I think it's actually probably one of the most exciting areas that's under development at the moment.
And Carl, from your perspective?
Yeah, so I think the important thing for me about any changes in triage and dispatch and things like that is linked to the appropriateness of it. And like Lisa made reference to make the patient experience a better experience. You don't need a paramedic, you don't need an ambulance crew, you don't need a person to come around to your house every time you potentially ring 999. The interesting thing is like you said, Lisa, is about the fact that these things have to be embedded, and that there's sometimes a slowness to embed things because we're not as risk averse as we used to be as a sector. I think we're a lot better than we were, but we are still naturally slightly risk averse to things. And sometimes in a controlled manner, you've got to take the risks to find out whether something is going to work, as long as it's done in a controlled, like I say, in a controlled manner. But if you don't try, you'll never know. And sometimes you can go round and round the houses talking about stuff, but actually you just need to get on with it and try it and see what happens. And as long as you can measure it, as long as you can got some sort of control mechanism around it to capture anything where it doesn't quite go to how we want, then we just need to get on with stuff. Because like Lisa said, it's all there. There's loads of technology out there. There's loads of other ways we can do things using human beings to actually have the interactions. We just need to get on and try. And I'm not saying we're not. All ambulance trusts in the UK which is where I am, are trying to make things better, are changing things. But I think there is something around pace that is always going to be our sort of ball around our chair, a ball around our leg, really, because it always has been, and we haven't quite got that sorted yet.
So I'd like to move on slightly and pivot towards engagement, really. And I think initially we'll look at community engagement. I'd also like to touch on something that Lisa notioned towards around interdisciplinary engagement, so this MDT approach, these multidisciplinary teams, because I think it really has affected for better our profession. But let's look at community engagement initially. And Carl, to you first, just around how do you see paramedics, what role do you see paramedics playing within community health and education? And indeed, a sort of another question on top of that would be, have we better engaged with the community over the past 5 years?
Yeah, so I think one of the key notions for the pre-hospital care sector, especially from a paramedicine role or an ambulance sector role, is that in terms of public health, we absolutely should be front and center of it, because we are around in the public domain. We are out and about in people's houses. We are out and about in people's workplaces. We are seeing things in a live situation which other sectors don't see, because the patient comes to that setting for their treatment, for their assessments, for whatever they need to do. Whereas we have one of the biggest privileges I've ever had as a paramedic is I can go effectively to someone's house who I've never ever met. We've never had any interactions. It's the middle of the night. I can knock on the door. I can walk into their safety domain, their kingdom, and we're in, and that is one of the biggest privileges that other settings within the NHS system or the hospital systems or the wider care system, they don't have. So in terms of community, we're properly embedded in it because we're going in their houses. You can't get any closer than that. And everybody sees the big yellow ambulance that drives around because it's a visible thing. GP surgeries can't really move. They're static sites. Hospitals can't really move because they're static sites. And although you've got things like mobile scanners and you've got mobile sort of things kicking about now, one thing that's always been steadfast within the ambulance sector is you'll see an ambulance driving down a road and everybody knows that that's an ambulance and everybody knows that there's an ambulance crew on board there. And if somebody wants some help, if I'm sat on standby, they'll knock on the window. If somebody wants us to flag us down, they'll stand and they'll wave. And instantly, you're in that community, you're fully embedded within it. And whatever happens with the paramedicine roles in the future, we can never, ever lose that. Because for me, that is the DNA of what we do. And if we do lose it, then I think that's going to be quite a sad day for a very personal opinion.
Yeah, and to you, Lisa.
Oh, yeah. I mean, I couldn't agree with you more, actually, Carl. And I think other medical disciplines who work with us acknowledge us as the team who will never say no. And I think, although that's been a shock and sometimes overwhelmed us, it is a very special, powerful thing. We're recognised as reliable, trustworthy people, a profession that can be relied on in that way. It is a huge privilege. Back to the question of, the interdisciplinary models of working over the years, paramedicine has always borrowed from other disciplines. We have grown our abilities by learning from other medical disciplines, by seeing, it needs me to have cardiac skills and going to the cardiac specialist and learning those skills. My patient needs me to have orthopedic skills and going to the orthopedic team and learning those skills. We've always done that, but I wonder whether we've really optimized our potential to do that. I think in my world, the universities have a strong role to play in this, especially the universities who are co-located with these big teaching hospitals, because the facilities and the opportunity is right there to link people who haven't thought about each other's world as much as they could have done to really see insight and opportunity to bring skills from other disciplines to our patients. There is a huge opportunity and potential to learn in those environments. And the other thing I think is really interesting is the move towards practice. because within that, we're all under this umbrella, haven't we, of allied health professions, working towards these agreed pillars. And I've given a lot of thought over time to whether these are the right pillars for us as paramedics, or whether we're just adopting these for convenience. But I think that these are the right pillars that do allow us to move forward. Leadership, education, clinical research. These are the things that are going to move us forward, and all of these pillars for opportunity for us to connect with others and expand our potential. So I mean, it's new for us to have these pillars to work towards. I think it's interesting and exciting to see where this takes us. But I think there's a lot of opportunity within this for the paramedic profession.
Lisa, can I just come in on that? Because you've made a really interesting point about the fact that we as a community can learn from others, and I absolutely sort of fundamentally agree with that, because there's times when you're on scene with jobs, or I have been on scene, and you just like, I just need to speak to somebody who knows about this, because with the best will in the world, I'm not a jack of all trades. I can't do everything. But the interesting thing about the learning is the fact that we do ourselves a disservice as a profession, because a lot of people can learn an awful lot from us. And the instances I'm thinking there is when you're out and about in your ambulance, you get sent to an RTC, for instance, and there's an off-duty hospital clinician on there who is absolutely brilliant at their role, but not in their setting. And absolutely, they can hugely help us, and we can hugely help them. And it's what we can bring to a party, what they can bring to a party, because there's certain skills in the pre-hospital sector, the versatility, the adaptability, that we're just brilliant at, and we should sort of pat ourselves on the back more for that. And actually, people can learn from us that, you know what, we haven't got the perfect kit here, but we've got to get on with this, and we can't just sit here, so let's just get on with it. And actually, it really offers a real scope for, we can do certain things really well that other people can't, that sometimes you can't be taught, because it's just how we work. And it's really interesting that we have to acknowledge that learning is bilateral. And yes, we can learn from senior clinicians, but absolutely, they can learn from an ambulance support worker on an ambulance. And when we realize that, and when we acknowledge that, everybody will then improve, because it's not about a hierarchy. It's about your level of knowledge of what you can bring to the party.
So let's look at pivot slightly and look at technological advancement, because I think one of the things that the profession has undergone over the past few years is a real technological revolution, just from airwave radios, or indeed web radios, which communicate over different modalities, MDT, some mobile data terminals, the way we conference, the way an EOC, or an emergency operations center, is set up. And I guess my question, and I'll pose it first to you, Lisa, is really, how have we seen the way we work as paramedics change due to technology? And indeed, has it made a significant impact? And it may be a better question might be, has it made an impact for the better?
Yeah, it's a big question, isn't it? Because technology is opening up to us so much potential. I don't know how quick we are as a system to keep up with some of that. But the potential we've already talked around, for example, the potential around dispatch and engagement with patients in an early phase is facilitated now in a way that it wasn't. We just weren't able to do that before. And I still believe that our patients really need human contact but it's how those humans, us, how we use the technology available to us to make that care more timely and maybe more for that patient. I mean, yes, the system has evolved with lots of other using technology to improve communication, for example, going on to electronic patient report forms. Well, that has actually transformed things quite a lot. It's made research and data capture much easier. It's also improved massively, I think, the communication stream for the patient from the roadside all the way through to discharge. And in fact, my colleagues in ED will tell me that they now cut and paste from the ambulance paperwork into their paperwork, which then gets translated up to intensive care or wherever the patient goes after. So now, from having we used to hand over a scrappy bit of paper that if you held it up to a strong light, you could just about read what the paramedic was trying to say. Now we're actually for the patient's story and their narrative, which is really important. So there have been, there are these integrated links with technology that are moving things forward, and something with the hospitals has been a huge part of that. But there's more to do, particularly around, I'd say, patient follow-up probably.
Yeah, indeed, absolutely. And to your point around the transitions of care and transitions of information, and the data capture, which is vital, some key pieces of information actually, and being able to capture those accurately over time. Because as you were saying before, the surgeon doesn't see the paramedic necessarily, and the rehab staff don't necessarily see the paramedic, but it's really necessary to try and capture that information as accurately as possible, so there is a better picture for the rehab staff. But Carl, to your thoughts.
So for me, technology, whether you want it or not, technology is absolutely here and it's here to stay. I think some of the technological advances are just absolutely mind-blowing and absolutely on point with everything we need to do. But I also understand that there are risks to it. And one of the risks for me is when we get new technology, it's all singing, all dancing, and it just gets sort of, this is the new way of doing things. That's all right. But what happens if that new way of doing things doesn't quite meet what you want it to do? And therefore, once it starts, it's hard to pull it back. So I am absolutely all for sort of the technology within the system being utilised. But what has to happen is we have to fully understand its limitations, is one. And more importantly, it has to be joined up. And with all the technology in the world, it's brilliant. But if none of it talks to each other and none of it sort of interlinks with each other, it's absolutely useless. And what you end up with then is increased silo working, when in fact the technological side of this should be breaking down all these silos, because it should be seamless from A to B to C. So nobody has to cut and paste anything, because the surgeon, Lisa, who you made reference to, should absolutely, if they want to, be able to see the continuity of care from when I walk through the door at 2:00 in the morning. We don't have that currently, not within the area I work, and sort of the other areas don't. But if you're going to embrace new technology, you've got to make sure that it interlinks, because this is where we get the problems. This is where we get the miscommunication. This is where we get the breakdowns. Things get lost. This hospital uses one piece of equipment, another hospital uses another piece of equipment. That patient gets transferred. Nothing talks to each other, and that's one of my biggest sort of biggest worries with the technology, because it absolutely could be making a really profound difference, and it does. One of the ones is ECGs. You've got an ECG that you're not quite sure of, that you're looking at your patient and you're thinking, you know what, this patient is in a right angle. Look at the ECGs. There's things going off on it, but I'm not a cardiologist. I can read ECGs. I can tell you the MI that's happening, and we can go with it. But actually, if there's something that's just not quite right with it, they're going to question you when you make the telephone call to PPCI to say, have they got X, Y, and Z? And sometimes when you're looking at this ECG, you're going, I don't really know, to be honest. Can you just have a look at it? And years ago, you used to end up sending it any way you could, just so somebody could look at it, so you could have that joined up thinking. Whereas now with telemetry, your equipment, it's all interlinked. You press it across, that PPCI can use it, look at it and go, yeah, absolutely, we need to see that patient. We need to see them now. Splendid. Otherwise, that would have been a 15, 20-minute conversation on the telephone, trying to fathom out, are we actually doing this or not? And it's trying to make things easy and less complicated. We in the improvement setting, we talk about making it easy to do the right thing and hard to do the wrong. If you set the parameters so it's easy to do the right thing, and technology allows us to do that in certain settings, then we absolutely should be doing it.
I think that's powerful actually, and like you said, just reduce the friction in the technological space, so that actually there is this seamless transitions of care, and it's also it's also around workflows and user experience, even within EPCRs, electronic patient report forms, and how we engage with those as a large part of a paramedic's working day. So just to move the conversation on slightly, I'm mindful of time. And just two more topics really I'd like to explore with you both. One is an absolutely fundamental topic really around mental health of the workforce and mental well-being of the workforce, and you know, everything we've seen over the past few years through COVID and this incremental increase in demand profile. Could I get you both to speak, and maybe Lisa first, to whether you've seen an improvement really in support mechanisms, and then consequentially well-being of paramedics due to the high stress nature of the role, and indeed, could we do more, and maybe how?
I agree, Owen. This is probably one of the biggest and most topical questions at the moment, or it's certainly one that I care most passionately about, if I'm honest. I think that there has been some organic change in the workforce, which has really helped us. For example, more diversity in the workforce has a really healthy impact on well-being, because having different types of people with different opinions and thoughts and ways of doing things dilutes some of the strong toxic cultures that have predominated some things in the past, and maybe put pressure on people to be a certain type of person or to act in a certain type of way. And those false that false role playing is certainly a contributor to some of the burnout that we've seen in the past. Now, burnout in itself is an interesting thing that's multifaceted. There's all of the practical elements of being human, needing to eat, needing to sleep, needing to rest, needing to have a sense of belonging in a team. All of those things, perhaps our systems ebb and flow on how well we're able to cope with some of that. But from a burnout perspective, I think we are starting to understand what that is more. And I think actually sometimes it can, I've been challenged recently by thoughts that can be a sign of someone's maturity. They are just changing the way that they are, their motivations and their thinking around things. Now, I'm certainly not an expert in burnout, but I wonder if we change our perceptions towards this is something that we expect in our system as people mature, then we can develop different support process for people at different stages in and the different things that are affecting them. So I think there has been, I mean, I've seen the different teams that I work in, I've seen them spiral forwards and backwards with this, and some really, really good things coming in. And really good focus on supporting individuals. People feel valued and supported within the team as individuals has brought about some massive improvements. But I would say that one of the biggest things I think for critical care teams that makes a difference has been the introduction of teams of people who follow up our patients. So, for example, in our air ambulance team, we have a dedicated team of specialist, extremely experienced nurses who link in with our patients and our families after the phase of care that we've delivered. Now, previously, I might go out to a patient on the worst day of their life, and we have this phrase in our minds, the phrase perhaps we aspire to, that our patients didn't choose us, we chose them. We have chosen to come to work every day to support our patients on the worst day of their life. The undertone within that is, you mustn't be having the worst day of your life. You have to put aside you being tired, you being hungry, you being whatever it is, because you're a patient. And that's perhaps asked a level of resilience of people that isn't always possible. And cultivating very resilient people actually means that you cultivate people who cope well and hide things in the system, so then the system can't evolve to manage those problems. The introduction of these this amazing team of people who follow up patients is that when I go to that patient and it's the worst day of their life, and they're having this terrible moment, I spend some time with them, and then I'll say to them, I'm so sorry that this has happened. And before I used to just have to say to them, I'm so sorry this is happening to you. I'm so sorry. And that would be it. And off I go. I would leave them with some paperwork. I would leave them with whatever it is, and then I'd be gone. And you do carry that sort of moral pedigree back with you, don't you? But if you then embed that patient or that family or their onward care into a supportive network of people you trust, and you say, "I'm so sorry this is happening. Please, can I connect you with our team who are going to look after you, who are going to make sure that you get, they're going to follow you up through your treatment and help you with your onward referrals and everything. They're going to see you through this process. Or I'm so sorry that you've lost your loved one, but I'm not leaving you on your own. I'm leaving you with a supportive team." Has been a huge bringing in those teams of people has had a huge impact for critical care teams in terms of not taking away and carrying the moral injury burden of every case, but sharing that moral injury and burden. So sharing that burden, I think, has been huge, and that's probably been the biggest development that I've seen in the.
Yeah, that is huge, Lisa, actually, and again, the continuity of mental health care on both sides of the part of the field, really, both the patients and the clinicians. Carl, from your side.
Yeah, well, I think nowadays it's just so nice to see that burnout and sort of people who are having mental health struggles, it's an accepted thing to be discussed now. It's not something that needs to be hidden away from. It's not something that you need to brush under the carpet, stick a smile on your face and say everything's absolutely, tickety-boo and hunky-dory, because, it's not nowadays. And people have got an awful lot of things going on in their lives. The world in which we work in as a role is more stressful than it's ever been. The things that are expected of us within the paramedicine world is greater than it's ever been. And because that's new to a lot of people, I know it's been the last few years, but in the grand scheme of things, it's a lot of these improvements are still quite new. It's a big burden to take on. And therefore, unless you get the support around managing that burden, then you're always going to have problems. And I'm not saying that we're not going to have problems in the ambulance service or in the pre-hospital setting, because we are. See, there's jobs that I've been to, that I've seen, that when I drive past them buildings on a weekly basis, that job will never ever go away. And in a way, that's part of the privilege, because you were there dealing with that patient in absolutely the worst state that they've found themselves in. And that is something that I take with me. It's an accepted part of the job. However, I now know that I've got support mechanisms in place if that starts having a negative impact on me, because I can now express myself to professionals, even just to my peers. Because in the crew room now, it's accepted to talk about things, to talk about how jobs have impacted you. And for me, that's a really, really sort of powerful tool, because even when people leave the ambulance service to go into different worlds, whether it be primary care or wherever they choose to carry on their professions, that burden is still with them. Them thoughts are still with them. Them jobs that they dealt with a few years ago that they might not have dealt with properly, that I've talked about before and with you, in my filing cabinet, never quite tidied that file up. I've just rammed it in the back and hope I never see it again. They occasionally pop out at you like a jack in the box. And actually, might be in primary care at that point, but that job's still not sorted out. And therefore, it's really important that, although we've got the acceptance now that actually talking about mental health is really important, it's not just about us. The entire system needs to be fully on board with it, and it all needs to be integrated. Same as the technology side of things. It's all about the integration now, because of the way the world moves on.
Listen, that's fantastic, Carl. And I very much have echoed your points in the past, actually, around the mental filing cabinet. Just due to the adage of time, I'm mindful we have sort of reached the 45-minute mark. I think it's a great place to finish, and it's great to see, both from Lisa, like you said, the evolution of the continuity of mental health care on both sides, and then, as Carl, you were saying, just the decompression and the sharing, and actually just the ethos of it's okay to not be okay, and it's actually starting to normalize how challenging the workflow and the work environment is. And I think that's a great evolution of paramedic practice, that we are starting to normalize the disparate working hours, the atypical presentations you see, the actual the mental strain it can put on you, and indeed the mental anchors, as you were saying, as you anchor to all these different things in the environment, which you can think from previous patients and previous incidents. So I want me to say thank you for both of your time for this last 45 minutes. It's great just to have you both on. We're going to hear, no doubt, from both of you actually over the next few weeks from different episodes and series. And it's just great to catch up. So thank you to you both.
I will just say, Owen, that the paramedics of the future are going to do better things than I ever did. And I'm really looking forward to seeing where the profession grows.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.